We also have a person with lived experience who is not listed as one of the presenters, who's going to open the panel with her comments regarding the importance of engaging spirituality in a recovery process. And so Alice Washington is going to follow me and sort of open us up for the day with those reflections. But my job as the facilitator for this particular presentation is also to introduce you to our speakers for the day, and I am going to read their bios. I was asked not to by one of them. They're all so humble, but I think that when you've done great work, that everybody should know about that and understand the level of expertise that we have available to us in the counties and at the state level. So first, I'm going to introduce Kumar Menon. Mr. Menon is the Chief Community and Government Relations, is the Chief for Community and Government Relations for the Los Angeles County Department of Mental Health and reports to the Director of Mental Health. He serves as the department's liaison to the California Mental Health and Spirituality Initiative. Since 2002, he has played a leadership role in the department's Mental Health and Spirituality Initiative to engage and partner with the faith community and support the use of spirituality as a resource for recovery and wellness. This has included the launch of an annual educational forum in 2002, the launch of the Clergy Advisory Committee in 2004, the launch of resource and training for mental health staff, and the development of spiritual self-care tools for individuals. During his continuing tenure in the Office of the Director, Mr. Menon has had the opportunity to work closely with consumers and family members in many initiatives the department has undertaken, including engagement of the faith community in combating stigma. Holding a Master's of Science in Public Administration and having a background in healthcare communications, Mr. Menon brings a systems perspective to how public mental health may engage the spiritual community. Dr. Rocco Cheng, Dr. C. Rocco Cheng, is the Corporate Director of Prevention and Early Intervention Services at Pacific Clinics. He is responsible for planning and coordinating PEI services, Prevention and Early Intervention Services, for various ethnic and age groups in the clinic's 5-county service area. A licensed clinical psychologist since 1996, Dr. Cheng has worked on various positions and provided consultation to local, state, and federal organizations. He has served on 2 committees for MHS-OAC. He has directed the Asian Pacific Islander SPW of the California Reducing Disparities Project since 2010. In his capacity as the project director, he coordinates the 55-member statewide coalition to address the issue of disparity in community-defined strategies in reducing disparity. In addition, Dr. Cheng and his cultural responsive training team is involved in 2 statewide stigma and discrimination reduction projects, including the cultural responsiveness training for NAMI California affiliates and a workplace mental health with the Mental Health America of California. In addition, Dr. Cheng also advocates for the diverse community as well as the spiritual dimension of mental health through his involvement with several statewide coalitions, such as his role as a steering committee in both the Cal MHSA's Stigma and Discrimination Reduction Consortium and the Mental Health and Spirituality Initiative. See, they keep telling me, don't read mine. Gigi Crowder. Yes, you. A native of Oakland, California, is the mother of 2 biological children, 22-year-old twin boys. And if you've ever seen them, they are absolutely beautiful and talented and courageous, and has served as a foster mom and mentor to many more through divine intervention. Gigi is the Ethnic Services Manager for Alameda County Behavioral Health Care Services and has worked in the behavioral health care field for more than 25 years after completing her studies at the University of California, Berkeley. As a family member of several loved ones who have received private and public mental health services, she is a strong advocate for promoting culturally responsive behavioral health services for all consumers and family members. Gigi works hard to promote the use of community-defined strategies for unserved, underserved, and inappropriately served ethnic and cultural communities. Her current focus is addressing the needs of at-promise urban youth by utilizing upstream approaches such as resources offered in faith/spirituality communities. Gigi serves in the leadership role on several statewide committees. One of the highlights of her career is being inducted into the Alameda County Women's Hall of Fame for her work in developing programs to enhance employment opportunities for individuals with psychiatric challenges, and most recently serving the 2013 MHAAC Mental Health Achievement Award. Oh, go ahead, girl. And last but not least, we have Dr. Kristee L. Haggins. She is a PhD and senior associate on the health equity team and part of the Center for Multicultural Development at the California Institute for Behavioral Health Solutions, which used to be the California Institute for Mental Health. We merged with ADPI, the Alcohol and Drug Policy Institute, and changed our names. She is a psychologist and has extensive experience in university mental health, where she worked as a clinician, educator, trainer, and administrator with a focus on diversity issues and African American mental health for almost 20 years at UC Davis. Dr. Haggins currently serves as a project manager for CIBHS on a number of statewide projects designed to enhance health equity, and cultural competency in mental health and substance use issues. Dr. Haggins has a BA in psychology from the University of Southern California and a master's degree and PhD in counseling psychology from the Ohio State University. She is a certified mental health first aid trainer, applied suicide intervention skills trainer, and Safe Talk trainer. So we have a powerhouse panel for you today, and they have lots of experience and information, and hopefully we will have enough time at the end for you to have an engaging conversation that will help move services forward or your relationships with the spiritual communities that you serve or are located in the areas in which you serve. I'm going to allow Alice Washington to come up. Alice is a member of the CIMH or CIBHS. I'm still trying to get there. I'm Doretha Flournoy, by the way. I'm the Chief Operations Officer at CIBHS. And Alice is a much, much needed hand. She participates in coordinating all of the policy forums that you've been a part of and has served a leadership role in doing that. But she is also a person with lived experience and has a lot to share with us at CIBHS and the public mental health system as well. Alice?
Thank you. So, thank you. So, I have a BA in sociology from Stanford University, and I also have an AS in graphic design, and I'm pursuing a web design diploma and an MS in psychology. So I'm a little bit behind in school because of the policy form, but I'll catch up. So I grew up in the South. I grew up in Galveston, Texas, and we were taught to go to church. My great-grandmother, who was Native American, used to sit in the front of the church in the pews, and we'd sit behind her, and she was a matriarch. And so I grew up in a really sort of matriarchal family where we were raised in Baptist church. So I grew up with a faith in God and understanding that Jesus was here to save us. My mom and I eventually, and my brother and I eventually moved to East Palo Alto, and she played the piano for a small Baptist church. And that was the first time that I learned the song, Jesus Loves Me. And she made me sing it while she played the piano, because she supported the choir by playing music. So I had to sing it in front of all of these people, and I was like 5 or 6 years old. So that was my first experience with that song. And my mom passed away in March of this year, and I helped put together her service, and one of the songs that we sang was Jesus Loves Me. So Gigi wanted me to sort of talk about that experience because at age 23, I had a break. And that break was because God started talking to me. And I could hear him just talking to me. And I remember I was walking along the streets, and I eventually became homeless, but I was walking down the street listening to God, and my mom and her partner, they came and found me. And as I was walking down the street, and I was so busy listening to God, and I'm like, well, what happened? And so eventually she ended up taking me to the ER room several times to see what happened to me. And eventually I ended up in the inpatient unit, and they diagnosed me with schizophrenia. God didn't go away. So I continued to hear him, and they classified it as hallucinations, delusions, and voices. And they gave me those medications, Haldol, and all that stuff that really compromised my weight and everything. And so I ended up in residential care, made a lot of good friends, met a lot of homeless people who taught me how to live on the street and be safe. But God didn't go away. So I remember being in an inpatient unit, and just really somehow or another I was just walking in heaven, and I'm like, I didn't understand what was happening to me, but all I knew was that God was loving me, and he was just trying to take care of me. Eventually I had to learn how to get out of the inpatient unit, so I lied. I told them I no longer heard God. Your medications were working. I learned to act normal. I learned to hide it. And they believed me. I went back to my family. Eventually my mom let me go back into the system. And I met some young women from, I can't remember where they were, from Guam, and they were Catholic. And they brought me to the Catholic Church. And I eventually opened up to them and told me about my faith, and we all prayed together. They had their crosses, and they did their beads, you know. And so I ended up in their church for a little while, Catholic Church. And then I had a boyfriend, and I stayed with him for 2 years, and he was in the Mormon church, so I joined the Mormon church. Eventually we broke up, and then see, where else did I end up? I ended up in the Pentecostal church with another friend of mine, and I got baptized there. So I've been baptized probably 2 or 3 times in different faiths and different churches. And so, but you know, all in all, as I visited the therapist, I never told them once that God had come back. They kept asking, are you still hearing that voice? I said, no, I'm doing fine. You know, your medications are working. And go to church. Yeah, God's talking to me, you know. So the gist of it is probably about 5 or 6 years ago, I decided to go back to church because I moved up to Sacramento to work for the California Network of Mental Health Clients with Sally Zinman. And I still didn't talk about the fact that I can hear God. And so I ended up back in church about 6 years ago and made a lot of friends. And I told them about my illness, and they didn't stigmatize me or anything. They just accepted me as a friend. I still have them on Facebook as a friend, and I still see them ever so often. But my truly best friend moved back down with her family. But they didn't stigmatize me, and they absolutely believed that I knew God and God knows me. And they glorified it, and they honored it, and they accepted me, and I grew with them. I grew in that social connection. I grew in that network, and that's kind of what happened there. So my social life sort of straightened up. And then Jay Mahler came to us from Alameda County, and he wanted to start a spirituality initiative. And so we did, and eventually it went to Connie, and now it's with Gigi. And eventually I left the project a little bit, but since Doretha and Kristee have joined CIBHS, yay! Nailed it! I've actually learned that I can open up and actually say that God is still with me. Amen. And so no medication, no amount of therapy can control what God does with his voice. Can't do it. So what happened, though, with my mom's death was quite beautiful. She died March 3rd around 11 p.m. Before she died, I was at work. I wasn't able to go with her because I couldn't see. And I know my mom would never want me to see her suffering or dying. What she did let me see was the white light that she was going into. So I was in my office, and I knew that this was happening, and I couldn't travel. I just couldn't see. My eyes were absolutely blurred, and I couldn't drive or anything. And so probably around 2 o'clock that afternoon, everything in my office that was white was white. And all I could see was the brightness of everything that was white. I could see the bright light. And I looked around me, and my eyesight cleared. And all of a sudden, I was no longer near blindness, but I could see. It's almost that song, I was blind, but I can see. Amazing grace. And so I sat there and I got, oh my God, this is what she wanted. This is why I couldn't see. And I watched the transition of her with this light. And I went home, and everything there that was white was white. And then she passed. They called me, and she passed. And you know why I was so comfortable with my mom? It's because she had been talking to me. God had let me hear her. And I knew she was with him. And I had talked to her earlier, and I said, God's waiting on you. And she said, who? And I told her friend that, and we prepared together, her transition to him. And she made it up there, and I could tell she's still talking to me. And I didn't grieve. I haven't really cried for her because she wouldn't let me. She kept saying, don't cry, I'm okay, be comfortable. And for the last few months, that's what she's been doing for me. All my family members who were not sinners came back to me and said, I'm up here, and they give me hope and they give me comfort. And so I don't hear her a lot, but I think, God has put her back to work. That was one of her things. I used to have these dreams. I used to see how she lost her work with working with children. She was an elementary school teacher, and they made her retire at age 70, about 72. And I used to dream about her experience with that. Now I no longer dream about that because I think God put her to work, because I don't hear her that much, so I'm missing her a little bit. But that's what Gigi wanted me to tell you, is because, the Western world defined my spirituality as schizophrenia. And it really wasn't, because he didn't go away with the medication. He stayed. That's it.
Thank you, Alice. That's the first time I'm actually hearing your full story. Beautiful. Thank you so much. Good afternoon, everyone. Alice's story kind of tells you the central reason why LA County Department of Mental Health started collaborating with the faith community. We wanted to find ways to support the strength. I mean, old days, people may not have recognized that as a strength, but we think spirituality is a strength in recovery for a lot of people who are getting services from us. So today, I also want to thank Doretha and CIBHS and Gigi for inviting me to present at this panel. Today what I'm going to talk about is a couple of key things that LA County did that had a lot of impact over the course of 10 to 13 years. And some of you may already know what we have done and continue to do. The first thing is our annual conference. How many of you have attended our annual conference? Well, not bad. Yeah. Second thing we did was start a clergy advisory committee. Now, the annual conference we started in 2002 really with the intent of using the faith community to combat stigma, especially for access to underserved populations. It was based on our effort to correct the disparity, especially in the Latino population that I think we heard in today's or yesterday's presentation. The gap is huge still, utilization versus population percentage. But we started the conference with the idea that we want the faith community to know about mental illness, that recovery is possible, and we wanted to give them examples of recovery. So naturally, our planning committee involved our Consumer Affairs Division. People told their story just like Alice did. NAMI was there. We had a NAMI member at every table. We had a clinician at every table to answer questions about mental illness, etc. The focus on stigma initially, although was access to care, but we wanted to reduce disparities, eventually over the years we found it did something else. The stigma reduction also helped create conversations in the faith community so that people in the community could get support, whether it's through their faith organizations or otherwise. And the word could spread. The basis, we had a kind of strategic basis for going to the faith community. The first strategic basis was our director. Our director, Dr. Marvin Southard, was a firm believer that we needed to attend to the whole person, that the recovery process involved the whole person, and we needed to find out ways to work with the faith community to achieve that. The second strategy was that in some of our early research, we found there were two ways to get to populations, underserved populations, especially minority populations. One was through primary care. Second was through the real primary care, which I call spiritual community, because that's where people go first. Well, for people who are seriously don't have anything else they can go to. But a lot of the conversations happen in the spiritual community first. I'll fast forward to an example just to illustrate that point. We're currently working on a project with a faith community in one of the cities in LA County. And the pastor, we were invited in. We didn't go in and say we want to do something with you. The pastor tells us about the pain he hears every day. It's happened to be a Catholic parish, so there's confession involved. But he hears pain every day. And his question to us in those terms were, how can you help us address those pain? And obviously that pain takes many different forms. But what we found out in the clergy conference approach we took was that they were not just opinion leaders for underserved communities where they could actually help us reduce stigma. They were actually first responders. One of our early members that participated in this tells us a story. By the way, this was way back. Our system is way better now. How he had to wait in his church space, watching the individual really smash things in the sanctuary, waiting for PMRT to show up. I mean, our system took that long to respond in those days. But working collaboratively with the faith community, we feel that we can address some of that. Not only can we really educate them about immediate attention to who is in front of them, what they're presenting, but also how to interact with our system. So our conferences not only did it address stigma now, but also addresses ways they can connect people to the system. And the last piece that our conference started to address now is about partnership. And I think the theme of this conference was partnership with primary care and substance abuse systems. But partnership with faith community in LA County's experience has taken many forms. Initially started as very informal things. In some instances, it started as coming together to talk about what the community needs are, like it happened in one of our service areas. LA County is divided into 8 service areas. In South LA, the conversation was with church leaders on what are the community needs, what are the high needs in this area, how can we address it? But that changed. Once this conference came on board, that conversation changed. And I'll get to that in a second. What else did the conference do? It allowed certain initiatives, local initiatives, to begin to address issues already, which, for instance, in Hollywood, we have healthcare partnership. It's a partnership between businesses in the area, but led by a local church that partnered with mental health, eventually brought in health services and public health, and they hold a open meeting, I shouldn't say meeting, a fair every Wednesday where homeless people in Hollywood can come in, get their basic services, get their screenings, and it's been going on since 2004. And it's well attended even today. What else did the conference do? It had, I think, we'll take some credit here, some statewide impact. It gets mentioned by many other counties as a starting point in their thinking about how can they formally address faith communities. The last thing I want to mention about the conference is that we were able to sustain the conference all this time because of MHSA funding. I remember our third conference, we actually had to rely on a private foundation to fund that conference. I think about 300 people showed up. So MHSA funding has been important in continuing that all these years. The second component that I want to mention that some of you may know is the Clergy Advisory Committee. You know, what is that? It actually came because of the conference. The conference was talking to the faith community, educating them only once a year. There were needs coming to us from conference attendees saying, what about this? Can you come to our congregation and do this? I see people in my food line that I know need help. Can you do anything? Can you outplace workers in my congregation on a Sunday to address these issues? So we figured we couldn't just jump into this because there were a lot of system things that need to be in place to do this. We said we needed to get some advice from the faith community. We can't just simply say, no, we can't do that. No, we can't do that. We needed to learn to work with the faith community. So we started the Clergy Advisory Committee. Now it's about 40 members strong. It's countywide. Representation is countywide. And it's interfaith. It's very diverse. And eventually grew to include our service area staff. Again, 8 service areas, 10 million people, very diverse from, you know, northern part of the county in Antelope Valley to Long Beach. Centralized meetings are difficult, but we stuck with it. The person from Service Area 1, which is the north part of the county, may not come to every meeting, but does come occasionally just to stay in touch. But what that kind of meeting did was not just have that conversation with faith community on what we should do, how should we approach things, but actually encourage the local service areas to do stuff. And I'll get into that too. It also had a role in pushing us in making actually the connection with the initiative that Alice mentioned that now Rocco and Gigi are part of, the California Mental Health and Spirituality Initiative, which then made us go in the next step, take the next step really. That is, You can talk to the faith community from a systems perspective. What should we do here? What education can we provide? Can you help us fight stigma? But what about people we are serving? What about supporting their spiritual strengths? What if that is key and a constant in their recovery? How do we do that? And so Clergy Advisory Committee was critical in helping us think in that direction, making those connections. And therefore, it really had a central role in some policy we had to develop to address that. So now let me list, having kind of given you a quick overview of those two things, let me kind of list the impact those two have had. The first one is expanding that local relationship. I already mentioned Hollywood Healthcare Partnership. The South LA Connection, what started as a clergy breakfast in '98, became actually an informal referral arrangement where people from the congregations were referring people to the mental health system, and they were working together and supporting some of the members in the community. Nothing formal, informal. Nothing on paper, informal. The other service areas started their own local meetings because I think it was the lady from the Korean Center in Orange County that said, things have to be local. It's so true for connection with faith community. We can have the centralized system to encourage things, talk about things, gain strategies, etc., but the connections have to be local because that's where we need the support. So all the service areas, 8 service areas, started their own meetings, own partnership efforts. But it was starting to be just meeting with no further steps than stigma fighting, that creating mental health awareness, etc. We needed to think more, and we didn't have a vehicle for a long time to take it to the next level. A couple of things came in to help us get there. And one of them is MHSA. MHSA funding allowed us to do some of that. In fact, one of the program heads here, Machala Ward, is in charge of one of the efforts to do just that. It also helped us, the centralized process also helped us, therefore, formalize our collaborations through MHSA funding. We have a few contracts, etc. In fact, perhaps one example, at least of a statewide example, is Kristee is going to mention later on. A couple of other things came out of these centralized efforts. One was the concept of community chaplaincy. It spawned a lot of, we haven't accomplished that yet. You may ask what that is. We felt that our system, if and when it gained competency to address a person's spiritual interests in their recovery, still needed to make a connection for that person into the faith community. And in many cases, that's difficult. You need to understand that community, how they operate, etc. We felt a cultural broker, like a chaplain, institutions have chaplains, why not community mental health? That we could create a cultural broker that could do that. It's on hold, but we're working towards it. But what it did spawn was the latest iteration of our outreach effort, the Clergy Academy. I don't know if you heard Dr. Southard speak yesterday. He mentioned that. The Clergy Academy, again, based on where we started with the conference and with the advisory committee, the Clergy Academy has 25 topics. And some of them have been chosen by the faith community. Most of them have been chosen by some of the things we have learned in the process. We currently see it as not your usual outreach and education, which I think kind of falls into mental health promotion, where it's all about access to care, where we'll tell them about mental illness, mental health system, how to gain access to it. We feel this is taking it to the next step. Next step in the sense that it's building capacity in the faith community. Building capacity for what? Some of it you'll hear again from some of the other presenters. But building capacity to provide support, mental health teams. We actually used a toolkit that was put together by the national organization Pathways to Promise that tells a congregation how to create a mental health team. It doesn't need any professionals in it. They may have professionals in the congregation. What does the mental health team do? They learn about mental illness. They can address people's nominal needs, decide how best to handle those needs. In many cases, it's really a team that can keep the person in recovery as part of the congregation, be inclusive, instead of, I don't think we want them coming back for service anymore, to saying, come back, you're welcome here. And then if they have any episodic issues, address that when it happens. I have to wrap up. I just want to mention one quick thing, that the policy I mentioned had to do with a whole other part of the thing we did about educating staff. We started with parameters that are guidelines. We have policy in place. We've been working with CIBHS to have multi-level training to teach our staff about how to address spirituality, how to assess it, how to include it in their care recovery plan in manner that meets the state requirement for billing, etc. It's been if you have time and you have questions, I can answer more about that. Thank you very much.
Good afternoon. Again, my name is Rocco Cheng from Pacific Clinics. I also belong to the Los Angeles Clergy Advisory Committee and on their executive board, as well as the statewide mental health and spirituality initiative since 2007. It's such a pleasure to work with these two wonderful persons and such a supportive teamwork. Thank you. And also, by the way, Alice was a member of the statewide initiative early on. This afternoon, I'm going to take some time to talk to you about some of the things that when we work with the diverse communities, I would focus specifically on the API communities. What does it take and what is the role of spirituality when we work with the API communities? Let me start by quoting some survey that our statewide initiative did from 2008 to 2009 to over 50, I think it's 52 out of the 59 mental health directors in California, their outcome and their report. Spirituality is oh, by the way, I have handouts on that table next to the cake. As long as you don't touch the cake, you can take the handout. And there's also a conference information which I'll talk about later. Spirituality is an important recovery resource in mental health system. 92% of the mental health directors at that time agree that it is an important resource to help our consumers recover. There's another question. It's an important wellness resource in the mental health system, 94%. Now, it is part of the multicultural competence, 98%. And I have not come across some survey with such a high percentage. Now, it's interesting when we get to the next question. It is appropriate for public mental health system to address spirituality as a resource in mental health prevention and treatment, 76%. So on the one hand, we know that it's very important for the people we serve. At the same time, there's a consideration, how do we do it? How do we build it into our public mental health system? Where will we be attacked by separation of church and state? And that is an issue that our statewide initiative has been talking for quite some time and came up with some white paper on that. And so I think that remains to be a challenge. Yes, indeed, spirituality is such an important component in a whole person's wellness. But how do we incorporate that without getting into the policy issues or funding issues? This is one of the reports that we did, the API disparities report, and I have few copies of the executive summary. If you want to get it after the talk, I'll be happy to share with you. In our work in the California Reducing Disparities Project, we do focus groups around California. We ask them about wellness and what does it mean when we talked about wellness, what comes to mind. And you could see that, I don't have a pointer, so I'm going to use my finger, that spirituality is certainly one of them. It's one of the 6 dimensions: physical health, emotional well-being, social relationship, family relations, financial stability, and spirituality. So in the API community, spirituality is an integral part of wellness. When we want to talk about, when we think about wellness, and this morning you heard about Ms. Mariko Khan talked about we want to work with our body, mind, and soul. And it's integrated in the Asian communities as well as the Pacific Islander. So wellness is not an unidimensional concept. Spiritual balance is crucial as physical and mental health in maintaining a whole person wellness. And we need to consider spirituality to work effectively with the API communities. Now, this is the part that many people have some concern that are we preaching to the consumer? Are we trying to use our power to influence them? And I see that, and many people see this differentiation of spirituality and religiosity. Religion often refers to a more organized faith. A spiritual person may or may not be religious. To me, that spiritual person, it could be you looking inward to reflect upon the purpose, the meaning, the value of our life as an individual, our relationship, our connection to the outside universe. Maybe there's a bigger self, whether it's a he, it's a she, or with name or without name, but there is some purpose. And spirituality could also be one's relationship and connection to the bigger self. Now, if we see it that way, I also want to introduce some cultural tradition in the Chinese culture. This is a painting, and these are the landscapes. These are the people. So it's an illustration of the human beings' relationship to the nature. In the Chinese tradition, the human beings are one small part of the whole universe. But in our day, modern life, it tends to be exaggerated. That you are the 89%, you are 95%, if not 100%. So in the Chinese tradition, it is very important to look at one's relationship to other people, other living beings, or including the nature. We also talked about a balance system. I think that Mariko also mentioned that. Have you heard of 5 elements? Fire, water, wood, metal, that type of things. When we are not feeling well, we are not saying that you are sick, but rather we look at what's in balance. So balance is very important. And there's also inner 5 element and external 5 element, how they relate and connect to each other. That's very important in this cultural tradition. And how that relates to one's symptom and some personal experience, including suffering. A spiritual person could have a lot of pain, but the person may or may not have to suffer through the struggle. So these are some of the things I think is very indicative when we try to work with people clinically. What can we do to provide support, to provide resource in their recovery, in the prevention, in enhancing their resilience? The other thing that people talked about a lot is the karma, the concept of karma. It's what you do would lead. It's almost like whatever we do, we plant a seed. And then once the condition matures, once the time is right, the seed will start sprouting. You get the result. So you hear about cause and effect. And so you may come across some people in the Asian community who are thinking, oh, it's my karma that I'm suffering. That's why I'm not happy. I'm depressed. I'm so anxious. That maybe something I did not do good in the past. So that is a myth about karma, and that's not how I experience karma or interpret karma. But knowing that that's our consumers or family members coming, what can we turn it around and empower them and take an active role in the recovery of their mental health challenges. That is something that, if we have time, we'll get into that. Then, how it works in the behavioral health system in California, importance of connecting with clergy in various communities. I remember in one of our community forums in Modesto, a group of Cambodian monks came, and then they talked about it, talked about challenges in their community. One of the issues they talked about is family members just leave consumer in their temple because they don't know what to do with them. But then they're saying, we are trained as clergy. We know how to chant, we know how to preach, but we don't know how to deal with mental health consumers. So these are the first responders that we do need to empower, educate, and support. I guess this has a timer. And the Chinese community is very important to work with Buddhist monk or Christian ministers. The monk is very important to work with a shaman. And in the Korean community, you hear that it's so important to work with ministers a lot of the time. And even in the Pacific Islander, in Korean Samoan, you need to work with the minister, get their blessing, and then we'll be able to do a better job in reaching out to the community. Prevention is really culturally congruent, and then we need to look, and this is another issue. As we are looking at health integration, we all think about primary care. But there's a lot of people in my community who do not go to primary care physicians. When they have problems, they first go to their traditional healers, acupuncturists, including myself. I don't necessarily go to my family doctor. And so those are the things that we need to consider when we try to reach out to this community. These are the different sectors we want to consider to include. And this is the shaman policy in the Merced County. You could see that that's a shaman giving blessing, giving spiritual support and counseling to the patient. And in the picture here, you could see on the one hand, the patient has an IV. On the other hand, it has the thing. Do you see that? It's a blessing from the shaman. So it's very important. In the past, they have low compliance. They don't know what the treatment is about. They don't know what's the medication. Are they going to get drugged? Is it going to be cursed? But after that, the compliance rate has increased significantly. I think that when we work with the consumers, it's important that spirituality dimension could help clarify their own value and priority in life, and set a clear intention and understand the interdependent nature between them and themselves. Interdependence is such an important concept in the API communities. But you are not an autonomous living beings. You need to work with others. What you do would affect other people. You as an individual is also a member of a bigger group. And that kind of concept is very important. And we also encourage people not to resort to fate or fatalism, but to take ownership, to be accountable for one's choice and behaviors, regardless of what has been done in the past. But whatever choice they make now is going to impact their future. And that's how we could look at the karma differently. It's your free will. It's sometimes it's your own decision. And then how can they confront and not avoid challenges? Many Southeast Asian communities dealing with war trauma, a lot of PTSDs, and they don't want to talk about it, they don't avoid it, and they are wondering why do they have to go through the suffering. But having the spirituality dimension would serve as a source of support and helping them to confront the challenges, and also help them to put things in perspective. And then the last one, I smile whenever I come to this one, is relinquish and let go. It's like the parents. Have you heard of helicopter parents? Hovering around kids? And many Asian parents are that. In our parenting, we help them look at their own value, their meaning in their own life, how important it is for them to take care of themselves while they take care of their kids. Then at sometimes it's time to let go. When it's time to let go, it's time to let go. So this spiritual dimension will be able to help people reflect on these dimensions and move forward. This Kumar has mentioned a lot of the LA County DMH's efforts. So I'm not going to go into detail. The Clergy Advisory Committee And then they provide cross-training for clergies, mental health 101, for mental health people, spirituality 101. And that's part of the collaborative between LA County and also the statewide mental health and spirituality initiative. And also in the LA County, there is a spiritual parameters. What kind of things you could consider to integrate when you want to integrate spirituality into mental health system? I think you could Google it and find online for the documents. Or Sandra is here. Maybe she could also provide some references for you. In the community, when we were thinking about working with the community organizations, I just give three vibrant examples how in some of the faith organizations, Herald Christian Health Center in San Gabriel Valley, they are very strong in doing the healthcare prevention. It's very important to work there. And KCCD is big on housing. And then Buddhist Chiji Foundation do the disaster relief. And we do recycling program while they provide support. This is some of the things we do at the Pacific Clinic. We sponsor 3 spirituality conferences before the big statewide conference. We integrate into our service and spiritual group. I think in the handout you have some of the topics we cover in that. I got a signal, so I will wrap out in 1 minute. Recommendations. I think it's when we want to integrate spirituality into our behavioral health care, we need to be very mindful about maintaining proper boundary. Especially my way is not the only way. If we have the same or different faith subscription, what can we do to provide open space to support our consumer and family member in their journey to recovery, and always seek for TA and consultation. So I think I will leave the Q&A to the later, so Kristee and Gigi could talk. I have some of the population report here, and then there is a conference coming up October the 8th of best practices for our community. If you have questions, we could talk about that later. Thank you.
Good afternoon. Can you all hear me? So my name is Kristee Haggins, and I'm with CIBHS, and it's a pleasure to be here with all of you. What I'm going to be doing today is telling you a little bit specifically about a project that we have been instituting at CIBHS for the last couple years as a kind of statewide effort. And much of what has been already covered and discussed in some capacity by Kumar and Rocco and Doretha, you may see presented here as well. What I want to kind of start with is giving you a sense of an affirmation that we use, and as I go through my presentation, you'll learn a little bit more about what peer support in congregations is, or PSC as you'll see it referred to here. And this is an affirmation that we created that is meant to be kind of the foundation or the grounding of the work that we're doing. And so if you are so inclined, I invite you, as I do and we do when we're working with our congregations, to just say this aloud with me as we set the intention for our time together. Ready? Abundant lives filled with healing. Oops, let's start over, my bad. Abundant lives filled with unconditional love, healing, happiness, and peace. Thank you. So peer support in congregations, as I just mentioned, is a project that was instituted from CIMH, formerly, also now known as CIBHS, with the purpose really to implement peer-based mental health prevention and early intervention services in faith-based organizations. One of the things that I think is pretty unique about the project and the work that we're doing is the peer aspect and component. That part of what you all know and that I think that is clear about our connection is the power of peers, the power of having people with lived experience, either themselves or with other family members, being able to support others in their recovery and addressing mental health and substance use issues. So our intention really was and is to build a capacity of faith-based organizations to be able to intervene early and to help divert mental health crises. And again, recognizing that folks that are able to speak about their journey and their kind of experience have power in terms of being able to instill hope and support as well as guidance for other folks. Part of our intention as well is to really build the skills of traditional sources of support within the community, to intervene, to refer, to counsel people who are at risk of living with mental illness and who come to their faith-based organization, their spiritual home, to help manage that mental health challenge. So you all know, and we've heard this has been part of our discussion already, about just recognizing that 1 in 4 folks who might be sitting on a pew are dealing with some sort of mental health challenge or substance use issue. And we know as well that people tend to go to their faith-based home, to their spiritual leader first when seeking support. And so part of our intention is to build the skills so that folks can have the skills necessary to respond when needed. We wanted to be able to build natural resources on the ground to help build a safety net that can help provide services. Knowing that people may not make the immediate kind of connection with a therapist or a psychiatrist or someone within the county related to their needs. One of the things that we have learned and that's been mentioned as well is the needs of the pastor or the priest or that leader in terms of being able to do this work. We did a survey when we started this project with the participants and asked some of the faith leaders kind of what their experiences were related to wellness and health and ways in which they were being accessed by their community members, and really heard a lot of feedback about we need help and support too, for our own kind of needs and our own challenges, but in terms of being able to really manage the number of people that are seeking help and support from us. I said earlier that the intention was really to have peers be a part of this process, so people within congregations to help support the pastor. And that has been a focus of the project as well. Another purpose of peer support in congregations is to empower the community to create indigenous strategies for identifying and managing mental illness. One of the things that we have done as part of this project is to work with a variety of churches across the state to help them to develop peer mental health and wellness teams within their communities, and really having them identify specifically what their needs are that are unique to their community, to their spiritual home, and then identifying what it is that would be helpful given those particular needs. Another intention and I think outcome of the project has been reducing stigma. Being able, again, to have people with lived experience, being able to have that faith leader have buy-in into recognizing the importance of wellness into recovery into that particular church or congregation. One of the things when we originally started the project was we were training the peers or the people that were identified as by their pastor to participate in some of the trainings. And we were doing separate trainings with the pastors and then with the peers, the congregants. And we heard very clearly, again, that the leadership was saying, we need this too. We want to be a part of the process of building our skills and being able to, again, reduce stigma in our community. So I mentioned that the project began a couple years ago at CIMH, and one of our original focus was working within the LGBTQ identified congregations. So we were recruiting and working with kind of same gender loving populations across the state of California, kind of recognizing the need, of course, across the board, but also recognizing that within this community that resources may not be necessarily available and other issues are present. We've had over 20 churches that have participated in the project and over 150 peers and pastors who've been trained. And as a result of their training, over 175 contacts that they've had with individuals that have either approached the peers that have been trained saying, I need help or support, or that they've been able to reach out to and provide referral information or support and resources to. So really pleased about some of that impact. I mentioned that the project has started with a focus really looking at the LGBTQ congregations in particular. And part of our efforts have really been to have an integration and a discussion about how do these various factors really integrate with each other as it relates to sexual identity or orientation, spirituality, and mental health. Again, recognizing that there are some particular needs of the LGBTQ population as we talk about stigma when it's connected to mental health, but then also the idea of multiple identities and the impact that may occur. The realization of the lack of resources that may be available to the population, and then acknowledging as well that there are frequently times in which someone has been ostracized or traumatized by their religious kind of connections. This year we are expanding the project and opening it kind of beyond the LGBTQ focus within churches and congregations. So what we've done, I mentioned that part of peer support in congregations has been really trying to customize an approach that fits for each participating church that's been a part of the project. We've also provided technical assistance to them in terms of what it is that they might specifically need. And some of that has been around, we're trying to develop a way in which we have people connect with our team members, and so helping them strategize around that. We've also helped them identify local resources and connect with their community kind of resources as well as county services, and have them begin to explore how to build upon the resources that we've been able to provide. I mentioned that we've worked with about 20 churches, and we've been having regional meetings and trainings and bringing them together. And so part of the impact has been cross-learning and support and collaboration, being able to kind of learn from each other about what are some of the key issues, what are the ways in which we can support our communities. We've done in-person trainings, and I'll tell you a little bit more about what those have entailed, as well as webinars that have been focused and, again, responsive to the needs. So doing kind of an assessment early on with the participating congregations to assess what it is that they need. So, for example, some of the webinars have focused on grief and loss or on substance use issues, in addition to domestic violence and sexual assault. Although we do offer kind of a customized approach to really support the participants in the project, we do have some kind of key trainings that we have been kind of offering to the participating congregations. And I'm sure many of you are familiar with all of these, so I'll just do a very quick kind of overview. And I want to kind of acknowledge that there may be mixed kind of reactions about some of these particular trainings that we're using, but they're evidence-based, and again, our intention is to create discussion and dialogue and really integrate any issues that are relevant as it might relate to mental health, to spirituality, and up until now, again, with a focus on the LGBTQ population. So we've done trainings on mental health first aid, RAP, Safe Talk, and ASSIST, Applied Suicide Intervention Skills Training. 2 minutes, okay. One of the things that we really hoped and have been really pleased to see happen is I mentioned that we're having the participants create mental health and wellness teams, and have really asked them to identify what is it that you want to accomplish within your congregation. Yes, the trainings help build the capacity of the entire team to help support beyond just the work maybe that the senior minister or leadership or pastor might be implementing, but what is something that you can concretely do to create change in your community? And here are just a few examples of some of the things that churches have been doing. So homeless and food ministries, that's a kind of common, I think, resource or ministry within a church. But they have done other things in terms of being able to include mental health, behavioral health kind of resources in backpacks that they're providing to people, or creating where they would normally do like a 2-minute kind of overview or sermon and making sure that they're integrating mental health issues. specifically celebrating Mental Health Awareness Month or other kind of mental health awareness days, bringing in speakers, using social media. So one church in particular took a stance in terms of saying, we're going to create a Twitter kind of process where we are constantly kind of feeding our membership issues that are going to be supportive to them in their awareness of mental health and substance use issues, creating Facebook pages, creating and starting support groups that are specific to their needs. A couple of churches and congregations have been kind of working with us and getting support around how they might develop or start clinics within their congregations. I am almost out of time, but I've got to get a couple things in really quickly. We've also noticed, so what I mentioned was we were asking for kind of broadly, what might you implement within your congregations, but we were also wondering what's the impact been specifically for their involvement. And so we've gotten reports and feedback about team members who've been able to intervene on the spot when members have maybe been in crisis in the middle of a sermon or before a sermon and be able to apply the skills that they've used. In the ASSIST training, which is an intensive 2-day suicide intervention training, immediately, actually the second day of both trainings that we conducted this past year, peers were called into action by someone who was sending a text message about being imminently suicidal. The use of self-care. So being able to apply RAP principles not only to themselves, but within their congregation and identifying how to do that and apply that. One pastor in particular talked about how they were really pleased about the folks who are participating in the project coming back and wanting to make a difference and to create a change. And they are one of the congregations that's created a hope team within their congregation. We're also really pleased to, from some of the participants in the project, 5 churches in Alameda County collaborated together, and with our support, we're able to write a grant proposal and actually receive 2 grants, the Innovations 3-round grants that are focused on building, again, the capacity and training and skills within Alameda County for the LGBTQ population, LGBTQ2SI population in Alameda County. What I'll say just in conclusion is we're excited about the project. We are continuing to recruit for this coming year. I do have a few handouts and brochures, and I'm open to any questions that you might have about the work that we're doing. I will just close by saying we see this as a kind of drop of the pebble in the pond, right, where you see the ripples that just extend beyond the work that we're doing. And part of what we heard as the feedback from the participants is the project and the trainings and the opportunity to do this work has created an individual kind of shift and awareness for themselves, but it's also really allowed them to be a resource within their congregations, within their families, within their friendships, their coworkers, that it expands beyond just the work that we're doing. So with that, I invite you to contact me and we'll see how we can move forward. So thank you.
Yes. So I'm Gigi, I'm the Ethnic Services Manager, as was announced by Doretha. Thank you, for Alameda County Behavioral Health Care Services. And I'm accustomed to doing training, but it's hard for me to do it when I don't know who's in the audience. So when I'm presenting trainings, I usually like to do an icebreaker. You guys have been sitting for quite a while. When I started working in this field, I understood right away that in order for me to make contacts with communities of color, ethnic communities, I had to engage who they identified as their cultural brokers. I also knew I would often be in front of people from diverse backgrounds, right? And so I had to find a universal language that is common for all folks, that we all resonate around. And we partook of a universal language around the noon hour. What was that? Any idea? We all had food. So we come from a variety of different backgrounds, but we all appreciate food from a variety of different backgrounds, right? There's something else that's a universal language that kind of speaks to individuals' soul when they're having a difficult time. So I did this icebreaker where I asked individuals to share with the rest of the individuals a song that inspires them when they're having a difficult time. Because music is also a universal language for many. There you are in the back.
I have a song that I sing in church called Love One Another.
Love one another. Love it. Now, do you have a gift of song? That means if you sing a few words, we don't want to give it back to you.
I dare not to.
Okay. Thank you.
Gigi, I don't particularly have a song, but I do like to listen to piano music, classical music, that,
Great.
you know, when I'm going through hard times.
And it inspires you. That's good to hear. Anyone else want to share a song? Mine is not a faith or gospel song. It's Shaka Khan. I'm every woman. It's all in me. And I don't have a gift of songs, so I'll stop there. And I generally do not do workshops or presentations unless people are wearing the green ribbon. So I will forgive some of you, but when you leave out of here, visit the Eat My Marriage table and wear your green, get your green ribbon or your wristband. Okay? Tony, you want to share?
No, I was raising my wrist.
Oh, okay. I happen to know you're a music person for sons in schools.
I think what inspires me, truthfully, it's old-fashioned, but our old Mahalia Jackson gospel songs that my mom used to sing. So that's what I would say.
Great. Thank you. Anyone else real quick before I go on with my part of the presentation? Okay. Well, he does want to sing. Okay.
No, I want to sing. I just want to offer another song that I enjoy.
Okay.
By Streisand. These boots are made for walking.
Oh, okay. Great. Thank you. So for me, when I saw the announcement about partnerships from CIBHS, I said, "Oh, here's an opportunity for us to identify natural partners." And working in the county system, if you're in the role of active services manager, you recognize right away that our faith leaders become our natural partners, because when you start making inroads into communities, especially communities of color, ethnic communities, you look for the leaders in those communities who will give you the pass, like this person is okay. So in Alameda County, when we got our Mental Health Services Act dollars for prevention and early intervention, we knew we wanted to start building a relationship with the Southeast Asian community and the Afghan community. Because outside of the country of Afghanistan, southern Alameda County has the largest population to the Afghanistan community, right? They live there when they don't live in their country, right? So we got a call from one of our board of supervisors, and she said, "I want you to start coming to these meetings that I'm holding in the Afghan community." So I went on a Thursday evening at 5:30 when it was in that south part of the county, and I lived in Antioch. But I went, and then I realized I was going to go to one meeting. There was 8 different sets in that community. And so in order for me to make inroads and for us to push forth an effort for us to fund from our underserved ethnic language populations, I had to identify individuals from those communities who would then give me a seal of approval to work with their community. I needed to do the same thing in Alameda County with the API community, which is the largest community we have, ethnic community in our county. But then I had to recognize within the API community, what? There's diversity. They can't just speak to one community. You have to go and work within all the communities. And I partnered with Rocco, Cheng, and we had our first API-specific conference in Alameda County for the Cambodian community, because they were trying to hold on to their program. And it was a beautiful day, and we had a lot of impact in that community. And then I made inroads with working with Janet King, Native American individual in Alameda County, who let me know why the principle that they have around being in balance was so important in their community. And I went to a wiping of the tear ceremony, and I learned a little bit more, some of the practices in that community. And then I started additionally working with the African American community. And so I grew up knowing that when I was a young girl, I'm going to hate myself, but in the African American community, we used to walk in and we used to actually, for kids, I see nurses. They weren't really nurses, but they had the hat on and the white clothes, and they were actually the ushers. And at any given moment, an individual could get touched with what we call the Holy Spirit, right? And fall out. And as a child, we waged bets on who would be next week. But there would be a Rocky and a Roland, and then it almost seemed like sometimes they would be trying to outdo each other, you know? And the nurse would come over, or the usher would come over, and they would say, well, as I matured and I got older, I don't see that as much anymore, but I did, and working in the mental health field, realized that some of what we pathologize is something that's on Sunday mornings, a lot of people quest for it. They actually want to be touched by this Holy Spirit. They want to know that God is speaking to them and that they're following direction that's coming from above. And I said, okay, I guess I'm going to also have to learn a little bit more about what the needs are in the African American community. I can't just stay in bed and watch Dr. Charles Stanley as I had been doing. I should get out there and reclaim my faith and find me a faith center because I'm doing difficult work. And I need to know that I'm doing this in a way that honors my community as well. So I did join a church, and nothing had changed. There's still someone there who's going to fall out almost every Sunday. And it was my sister. But then I started realizing, and I used to be embarrassed. So I was like, oh please, she wants to come to church with me. Is she going to do that again? But she describes a beautiful experience whenever it happens. And her life works better. And when I miss a Sunday, my life doesn't work as well. It's like I'm a battery. And I need to be recharged, and then on Tuesday I need to go to Bible study because I need to be recharged, because I need to be inspired. Because for me, the most important evidence-based practice now is prayer. And the most successful we use is a demonstration of love. So, in doing this work, I recognized right away, okay, we need to come up with some trainings in Alameda County. Jay set the foundation. We got the statewide spirituality initiative in place. We had diverse individuals from all across the state participating. I said, oh, is it possible for us to also do a conference like they did in Los Angeles County, Jay? What do you think about that? So many of us went down to Los Angeles in 2008. And then the statewide spirituality initiative decided that in 2009, we would host one in Alameda County. And to date, that was probably my favorite 2 days of work, because I got to look out into the audience and see people from a variety of different backgrounds experiencing for themselves what they had told us was really important to them. And the individuals that most touched my heart were the consumers and the family members, because in working in the mental health field for as long as I had, it always came up for individuals. It always came up that their faith was an important wellness tool and they wanted to have an opportunity to experience it. I knew that for inpatient setting, there's a question asked, which is, you know, what is your faith practice? So that's a requirement from JACO. But in the mental health side of outpatient, we shied away from it. For many years, people didn't know what my faith practice was, and it wasn't so important because it's not about me, right? It's about that individual and supporting them. And so when we started our spirituality work group in Alameda County, what was really, important for us to understand was that many of the group, individuals who attended the group didn't have faith practice that you would define as religion. And many said they were non-believers, but that they connected to something that was important to them, and that was why they were there, which was nature or some other thing, but it's self-defined. So spirituality in our definition for the state is self-defined, defined by the individual. And so for me, that was great because we didn't want to perpetuate this whole separation of the church and state. But I would say this, in any environment that I've been in, when I say, well, if you have real strong beliefs about separation of church and state, why don't you reach into your pocket right now and give me anything that says, in God we trust. Yeah. And not one person has ever felt it. I walk away empty. So I know that we have a lot of work to do to be engaging, and that's why in October 9th and 10th in Alameda County, we're going to have a mental health and spirituality conference, and we're again trying to use a community approach where we bring everyone together, and we'll have workshops from a variety of backgrounds. We'll have some Spanish language only presentations. We'll have some API language presentations. We'll have transitional age youth track. I was had the opportunity to go to an API conference and met an individual named Jason Chu, and he does this beautiful song. Well, he has a couple of beautiful songs, but one song that he does he says in there, he was an individual who was suffering, having a difficult time. He was actually cutting himself, so he was suffering later. And he cut on rap music and heard God. And so for him, that is healing through the arts. So once he was able to connect with that and start writing himself, that's where his healing came from. So for him, music is spiritual and rap music is spiritual. You don't often hear people refer to rap music as being spiritual. But when you hear his songs and you hear them over and over again, you hear how important this is, and you know that he has come up with a culturally responsive approach to meet the needs of individuals from his community and beyond who are suffering in silence, but he's able to express it in music, right? So one of the things that we did in Alameda County from taking in all that we've learned is we developed a mental health one-on-one training, and we use cultural brokers from all of those groups that I've gone to. We are a clergy roundtable. We said anyone interested who's a faith leader, pastor, rabbi, monk, etc. in Alameda County, please come to this clergy roundtable. Let's hear what you've been hearing from community members about the needs, and then we'll take the information and we'll develop some training specifically for having you meet those needs. So that's how we started in Alameda County. We were able to hire an individual, Minister Monique Tarver, who, as far as I've been able to identify, was the first person hired in that specific role as the liaison for mental health and spirituality. And so Monique then worked along with our statewide spirituality initiative and Dr. David Lupoff, and we developed spirituality one-on-one trainings. Now that was, we got the faith leaders prepared, right, from a variety of ethnic backgrounds and faith practices. So now we need to have our mental health provider community ready, right? When individuals come in and say, this is my faith and my practice, and so now I need you to honor it in the work we do. I need you to know that I have a belief system, and for me, if I don't have you find a way to include my faith, I don't think that I'm going to have as much opportunity toward recovery. So we knew this was true also in the African American community. Every community I go in and say is most important to their community. So I stopped using those broad generalizations. I know it's important to African Americans. And so African Americans have faith leaders who we also have drilled down and started training specific, but having the Each My Matters statewide initiative allowed for us to have an approach where we're not just reducing stigma and disparities, but we're also stigma and discrimination, we're also addressing disparities. Because we get to talk about how African Americans are receiving their services in our system, and how in order to do it and do it in a way that's honoring them, you must include the faith leaders, because the faith leaders in the African American communities have been the voice, and any advancements that we made around a social justice cause, but this is a social justice cause, has been done being led by faith leaders. So we do the mental health 101, we do the spirituality 101, and we have a training called A Bridge Over Troubled Waters, which further illustrates the significance of faith and spiritual practices for African Americans. No matter where you go, whether you're watching a football game or an award ceremony, you can have Little Wayne, you can have something in his cup that we probably think he should have in his cup. Once he gets his award, he's going to say, what? First, giving honor to God. Whether it's little Kim, who might not be fully clothed, he's still going to say, first, giving honor to God. Football player, first, giving honor to God. Right? So that's a pretty common core practice in our community. So I just have a couple of pictures that I wanted to show that will highlight. Doretha, this is probably where you have to come out. Yeah, that's how we did it out. Click on what? Okay. So the first, that is Allen Baptist Church in Oakland. After the Each My Matters Day, we had Each My Matters Day of Worship. So program that we worked with in Alameda County and across the state, you will notice everyone had on the green ribbon. This church is celebrating their 95th anniversary in October, And we were able to have such influence with not only that church, but 23 other churches across the state. And they all joined hands, and they all wore their green ribbons, and they sent it to us. And they're starting to have discussions about why each line matters in the African American community. And now, if you click on, well, that was one of our clergy roundtables. I wasn't supposed to show that. Monique had lost like 100 pounds. She said, "Throw away that picture. Never show it again." These are our 10 commitments. So we worked at Unity Church in Sacramento, and this is what the churches have committed to: eliminate stigma and improving outcomes, developing a mental health ministry within the church, hosting regular mental wellness fireside chats, whether you have a fireplace at your church or not, still called fireside chats. There's history as to why. You're to host annual mental health wellness trainings. We suggest May and October. Recognize and promote the state's, well, it's actually the National Week of Prayer for Mental Health. It's October the 7th this year. October 7th, the National Mental Health Day of Prayer. And it's my birthday on the 29th. And the Mental Health May will utilize wellness-friendly language in our teaching. So people first language. No conversations over the pulpit about individuals and making references to Jesus wasn't schizophrenic, because I've heard that before, and I've left the church when I've heard it. When I've talked to the pastor and he did change it, I can't say it. We'll dedicate at least one message annually. We actually thought 2. There's 52 weeks in a year. You can have 2 messages. And we're going to foster, cultivate, and develop collaborative relationships with like-minded organizations committed to promoting mental wellness in the African American community, and incorporate mental wellness training in church-wide events. Then there's also 10 commitments that we asked of counties that we work with. And I think there was just one other thing on the in there that I just want to share with you guys, and then the whole group will come up and take questions. It's not, it was on that. Yeah. And a lot of the work that we developed around how we work with the African American community came from our Alameda County African American Utilization Study we do, and had clergy roundtables specific to the African American community as well. And you would just be showing the first one, that PowerPoint presentation. It's just the first page. But I do want to recognize that in Alameda County, we looked at a problem we were having around utilization for African Americans, and we put a whole group of people together to come and start addressing it. And we used $1.8 million of our innovation dollars to start addressing it, because it's not okay for African Americans, in particular males, to get the bulk of their services in a criminal justice system, is it? No, that's not it. So thank you for your time. Doretha's the moderator, and then she's going to lead us through the next steps of how we will answer questions.
So I wanted to make... So we're going to open it up for questions and comments, dialogue. We only have a few minutes, and I see a hand already. Is it possible for you to stand and offer your question? I do want to say, however, that there is a strategy behind all of this. It's not just a warm, fuzzy feeling kind of thing where people who happen to be spiritual people who want to, converge mental illness and spirituality principles and concepts with each other, or this is about expanding capacity to respond to the needs of people who are living with psychological distress in the communities that we serve. You heard earlier in presentations, earlier in the big room, about the lack of capacity for the state or the county to provide services to the people who really need it, that we're losing, that we don't have enough doctors, we don't have enough social workers, we don't have enough psychiatrists. We have to in some way build capacity. I've heard it said over and over again that even with MHSA, we do not have enough money in this county to provide, in this state, to provide services to everybody who needs it. And so we have to engage every resource available out there in the community that can help us in preventing mental illness and also intervening early because the public mental health system, the place where we do most of our work, is going to be engaged in providing the seriously mentally ill with their services, and the rest of the folks are going to have to fend for themselves as we move into this world of integration. So it's important for us to get the ground tilled at this point, to get folks on the ground trained and aware of what mental illness is, and to help out in responding to the needs of the people who are in their specific communities. Question in the back.
First of all, I just want to thank all the panelists for your guys' presentations. I found all of them to be very helpful in the work that I do. I do have a question for Dr. Rocco Cheng. I hope I pronounced her name right. In one of your slides, the cultural tradition for Chinese, there was a bullet of pain and suffering. In that pain and suffering, are you referring to either the emotional or the mental or the psychological state of pain and suffering? I wasn't sure which one, or if there's any of the three.
Okay. Thank you very much for your question. I think that pain could be a physiological or emotional experience, but suffering certainly could be a spiritual and emotional experience. So sometimes when people are going through tough times, they don't necessarily need to suffer. Pain is there, but you don't need to suffer with it. And I think that what I was trying to separate the spiritual dimension from the other two dimensions. Thank you.
Yes. Kristen?
I teach graduate students, and I think that's one of the issues that come up here, as well as this idea that it's hard to have clinical models that often are being taught are really, how to integrate wellness and recovery, especially spirituality in some ways, because there's some suspiciousness of that. So I love the idea of like peer leaders and faith leaders have exposure to grad students. I mean, really to help educate them as well. And so I was kind of curious about your thoughts about just kind of making that connection with the training institutions and how we're preparing people in the workforce to actually really use spirituality well.
Kumar, you want to talk about your spirituality toolkit and what you've been doing with LA County providers?
And one of the reasons actually is what you pointed out, why we started training our staff. It's not just because we were reaching out to the faith community. I mean, you needed to do that anyway, but also the fact that they didn't have the training in their discipline when they, went through school. We have internship relationship with 8 institutions in LA County, and the director's office, I don't know about the other spots, we have 2 placements every year. Believe me, every year those 2 interns in their macro internship touches some aspect of our faith outreach and spirituality care. In fact, one of the UCLA intern was instrumental in us developing the training module for assessing spiritual interests of persons who come to us for service. Outside of that, we don't have any arrangements of taking our curriculum that we have developed for staff into the academic institutions. I can tell you about what we do for staff. It's a tri-level training. Now we're trying to condense it to 2 levels. We felt that needed an introduction that addressed their awareness of the importance of spirituality, plus any bias they may have towards caring for persons' spiritual interests, and even talking about their own as part of the natural conversations. Then the second step is really based on what our system needs are. How do you incorporate questions that can elicit answers under the umbrella of cultural considerations or cultural competency that fits into your assessment? And where do you enter that information? How is it relevant to that person's recovery? Where do you stop? Where do you not proceed anymore if there is some lack of interest or disinterest on the part of the person in front of you? And secondly, having got that information, how do you use that as part of your cultural formulation, and how do you put it into a recovery plan? One of our clinicians who actually did some of this work was asked, wait a minute, you're asking the person in front of you, have they been to church today? How is that relevant to mental health? So she had to explain to the person who asked the question that was not why I was asking the question. I was asking the question because part of the recovery plan of improving her socialization was this person to start going back to the church they showed an interest in attending again. So that's why she asked a question. So they're trained to put the questions about spirituality and the answers they get into that context. It'd be great if we can translate that in the academic institutions and training.
And I have been asked to go and speak to graduate level students about the work we've been doing around creating mental health friendly communities. What we learned is that in graduate schools and around, they don't cover spirituality as a subject. And on the faith leader side, they got one course on counseling. So that divide that Dr. Southard talks about there being a divorce between mental health and spirituality and them being in need of intense marriage counseling is really true. And so the individual that we use to do the training, Dr. David Lukoff, kind of gives a historical context for why, when the divide took place and why the divide took place, because of our three fathers of psychology having quotes that kind of didn't promote that faith and spirituality were important, and then us being trained and needing to unlearn what we were learned. Dr. Thomas, before she retired, when she spoke at our 2009 conference, she talked about her childhood and growing up and how in her formal training, it was unlearned out of her. Like, so she was taught not to. And so often we feel like when individuals access anything in a setting, like I think it was discussed today, where we put up a barrier, we have a clipboard in front of us, so we ask consumers 110 questions, and then when they access anything, we say, oop, can't share that with you. But you have to be willing to have the conversations about a person's faith and their practices. And so we are working with emerging students to tell them, don't exclude that part, because many consumers feel like if you can't share that part, if you can't take that from me, you can't have any of me. I'm going to be limited in what I share, so our therapeutic relationship will suffer from that.
Question?
Yeah, in the substance use disorder field, there's a long history, as you know, of spirituality involved with addiction recovery. I'm just wondering, my question is, what are you doing to try to, since we're trying to integrate now mental health and substance use services, are you doing anything to sort of incorporate the recovery, the 12-step, social model recovery, which involves a lot of spirituality?
You might have been here last time at the Mental Health Policy Forum when Minister Marcus Dancer, he was the African-American young man that talked about his faith as being a healer. And I thought since it was a policy forum that covered behavioral health and mental health, so I've been working with him because in Alameda County, we recognize that our substance use dividers are far ahead of us, and recognizing that for recovery, a higher power. But for some communities, they don't say higher power. They say Jesus, they say Allah, and so we're learning actually from the substance use disorders and utilizing individuals as cultural brokers in Alameda County from that group of individuals too, to help us advance our efforts and make the conversation complete and not break up body parts. Thanks.
Okay, thank you.
And I also have one slide I show that one of our group is on spirituality, and on 10-week session, there's a specific topic for consumers to talk about and how to utilize, and clinicians and case managers there, and how to utilize their spirituality as a resource, as a support for their own recovery in their own journey.
Just quickly want to say, we do use the substance abuse system's use of spirituality as an example on how a system can use it. Second, we are trying to create self-help kind of groups that address spirituality in our wellness centers. And to that extent, we have actually developed a toolkit. It's in the process of, we are trying to develop training for facilitators who can use that toolkit in actually helping people understand their own spirituality. I mean, when it happens, I think it'll be probably the first time a mental health system is actually directly addressing a person's interest in developing their own spirituality. And we have structured it in a way it's still within all the separation of church and state issues are addressed.
I think the co-location of services is also one of the, I think, best practices in the substance use field, where they've been able to offer support groups and AA meetings and things like that within the church, on site at the church, which made it easy for folks to access services. And certainly mental health can do the same. One last question, and then we have to close. I'm going to go with the young woman in the front. Sorry, thank you. So I think earlier what we've seen in some of the examples that Rocco brought up, and what we saw in the last presentation that was in the large room by Mariko Khan, is the use of cultural brokers is an excellent strategy for trying to develop services or develop strategies or develop products that would be relevant to the population that you're attempting to serve. The folks who know that population, who speak their language and understand what they need, will help you translate whatever it is that you're trying to create, if it's even, and of course identify whether or not it's culturally relevant and appropriate for that particular population. I think that is your first step in place to start.